the measures are and home care. The measures are gathered on admission and on discharge, and they are comprised of 4 categories of concepts. One is functional status, one is symptom management, safety outcomes, and therapeutic self-care. Many of the measures are based on data that are collected already in long-term care and home care through the INTERI. Long-term care and complex continuing care collects the same data with the exception of the therapeutic self-care measures. Moving on then, my screen is just, oh, there we go. We're on slide 4 now, and the C-HOBIC data set then, we have the measures that are the assessment measures and criteria. We have the documentation, and then we have the data set itself. The data set is, has been endorsed by the Canadian Nurses Association and the Canadian Nursing Informatics Association, of which all of you, I expect, are members. And the selected C-HOBIC data elements have been included, some of them have been included in the National Nursing Quality Report, the NNQR, and that is being led by the Academy of Chief Executive Nurses and the CNA. Furthermore, in January of 2012, the C-HOBIC data set was designated as a Canada-approved standard. In other words, it was approved by Canada Health InfoWay Standards Collaborative, which was responsible for approving health information standards, and it was designated one of these Canada-approved standards. The data set by sector is comprised of the concepts of functional status, and these are the activities of daily living as well as the independent activities of daily living. And you can see on the right-hand side of the screen which sector a particular item is included in. Some of them are included in all sectors. Some of them, for example, the walking one here shown is only included in acute care. Others, the independent activities of daily living towards the bottom are included principally in home care. Then the symptoms of pain, fatigue, dyspnea are collected across the system, as are the safety factors of falls and pressure ulcers. The therapeutic self-care or readiness for discharge criteria, of which there are 8, are only gathered in acute care and home care because obviously those are the only 2 sectors from which people are discharged. In complex continuing care and long-term care, people are there much longer, and the therapeutic self-care factors are not quite as essential to their moving forward in the system. That data set, the concepts that you just saw, are not phrased or were not originally phrased and coded in a standardized clinical terminology. So in the phase 1 of the C-HOBIC initiative that was funded with contributions from InfoWay, as well as the provincial partners, we mapped to ICN version 1, and subsequently when version 2 was released, we mapped to that. The mapping was done collaboratively between Canadian nurses and international ICNP experts, and it was validated by both sides. And in 2012, we released a joint publication called Nursing Outcomes Indicators, between CNA and ICN, who owns ICNP, a catalog of the C-HOBIC concepts, the terms, a coding structure for them, and that has been widely used internationally. So it was mapped to, the C-HOBIC concepts were first mapped to ICNP. Subsequently, as Canada Health Infoway moved forward and was focusing on clinical terminology for use in the EHR nationally, we then mapped the terms and concepts in the C-HOBIC dataset, and consequently those that were in that Nursing Outcomes Indicators catalog to SNOMED CT. Now, SNOMED CT, as you're all aware, I'm sure, is the standardized clinical terminology that Infoway has recommended as the preferred terminology for interoperability amongst electronic health records and EHRs in Canada. So a major aim of that particular work was to see if there was a way of harmonizing the ICNP catalog with SNOMED CT in order to meet that Canadian requirement. And what we did was we invited 16 nursing terminology experts from around the world, and they came together in Montreal. And some were from IHTSDO, the International Health Terminology Standards Development Organization, which owns SNOMED CT intellectual property, from the Nursing Special Interest Group of IHTSDO, so SNOMED experts. Some were from the International Council of Nurses, and they were ICNP experts, and there were 7 Canadians who were familiar with both SNOMED and C-HOBIC. The first cut at it of this mapping was done by colleagues in the UK on the National Health Services SNOMED CT team. They prepared a draft in advance, and then the other 16 of us sat down in a room for 2 days and went through that line by line, concept by concept, code by code. There were exact matches to SNOMED CT for the majority of the concepts. Several of the SNOMED CT concepts were broader than C-HOBIC, or alternatively you could phrase it as C-HOBIC was more precise than SNOMED CT. And there were 13 C-HOBIC concepts that were not present. And there are 2 examples there on the screen for you to see of items that were not present. Following that meeting, the Nursing Special Interest Group requested the addition of those 13 new concepts, and I'm pleased to tell you that they have been added to SNOMED, to the international release, and that has been available since January of this year. It's available by signing on to the IHTSDO website, finding the SNOMED browser, and then you can find the terms using that browser. So C-HOBIC implementation, the participants in it were Canada Health Infoway, the Canadian Nurses Association, and the participating provincial partners in Ontario, Saskatchewan, and Manitoba. And there are a number of underlying principles going back to our first phase of the SNOMED, of the C-HOBIC implementation across the country. And these are shown on slide 11 on the screen now. The first is the only things that have been included, the only concepts, I shouldn't say things, the only concepts that have been included have been those concepts for which there's empirical evidence that clinicians impact patient care outcomes. So there is research that indicates that for these clinical concepts that have been identified and included, that clinicians make a difference. Originally, it was developed in Ontario using the Nursing and Health Outcomes Project, and it focused on nursing concepts for which nurses make a difference. Subsequently, through the work that Peggy and I have done and through the various cycles of implementation, it's been revealed that these concepts are informative for physicians, for pharmacists, for physiotherapists, for occupational therapists, because they're patient outcomes. They're not nursing outcomes or physician outcomes or pharmacist outcomes. They're patient outcomes. And each clinical specialty profession contributes to a greater or lesser extent to all of them. But they're patient outcomes, and we know that they're patient outcomes to which nurses contribute. The second principle is that the focus has been on a consistent collection of data. So that means that people need to be trained how to use the questions, how to score it, and how to enter it into an electronic system, because we want it gathered once so it can be used repeatedly in different ways. So that the first objective is to be able to consistently collect the data and to do it electronically at the point of care, and that real-time feedback of the information needs to be available to the frontline clinicians in order for them to use it in planning and evaluating care. It can also be used offline. It can also be used for population health, but it must be available to frontline clinicians to use in evaluating the direct care to individual patients. The third principle was to avoid duplication. And so the data elements are integrated with existing facilities, admission assessments or discharge assessment. It's integrated. It should not be a separate C-HOBIC screen that nurses have to fill out that, as well as an admission assessment, for example, that is facility-based. The objective is have it be integrated so that when the nurses do their admission assessment, the C-HOBIC data is included, and then it can be extracted by the system and fed back as a C-HOBIC profile to the nursing staff. Fourthly, clearly maximize electronic capture through existing systems, and so we have been working with facilities and vendors to build these questions into existing assessments, and in fact to implement C-HOBIC as a system is upgraded or as a new system is installed. And then to provide access to the information for nurses and other clinicians, whether they be managers, researchers, ministry planners, provide that access. So the principle is gather once and use many. And then work with clinicians to help them understand the value of this data when it comes back to them, and how to use that data to inform their care planning and their practice. So in phase one, which began in 2007, and actually we started writing the proposal in 2005, it took us 2 years to get through the InfoWay hurdles and bureaucracy. and we had a 2-year cycle of funding. In Ontario, it was funded by the Ministry of Health and Long-Term Care, and in that phase, 122 sites were collecting the C-HOBIC suite of measures, and at that time in Ontario, and still, there was no provincial electronic health record. And so the data were housed at ISIS, and that database is a real-time database, so that provides nurses with access to the information about their patients and provides unit-level reporting to various organizations. So both the nurses on the unit who want to pull information about their patients and the nurse managers on the units who receive reports, aggregated reports about the profile of their unit, have immediate access to the data. In Saskatchewan, it was implemented in 30 facilities for a total of more than 2,100 long-term care beds in the Saskatoon Health Region. In Manitoba, it was implemented in 2 of the long-term care facilities for more than 1,000 long-term care patients. And they started out, they were originally only going to implement in 2 of the home care offices in Winnipeg, but they ended up, they found it useful, and they actually implemented in all 6 of the home care offices in the Winnipeg Regional Health Authority. And prior to this C-HOBIC implementation initiative, both Saskatchewan and Manitoba were participants in the INTERI contribution to CIHI, and they submitted, they had nurses gathering INTERI data quarterly and submitting it to CIHI. And unfortunately, all the clinicians that contributed data for about the INTERI criteria, all 400 plus of them, to CIHI, never got a report. There was nothing fed back to the staff nurses. And what our project did was pull out the relevant pieces from INTERI for which we knew there was a nursing component, and gave those back to nurses, and then nurses received the reports on the clinical outcomes of their patients in long-term care, and were able then, through this project, received a great deal of education about how to use those data to evaluate and to refine their patient care. In phase 2, which ran from 2012 to 2015, so if you've done your math, you realize we've now been at this from the time we started to write the first proposal for 10 years, Peggy and me, as well as others, but that's where we started. In phase 2, this phase included the design, the development, and implementation of a synoptic transition report. We were really focusing on, okay, so we got this information, we do it on admission and discharge in home care and long-term care. We also do it quarterly in long-term care, or if there's a change in status, but it stays in these silos. Patients don't stay in the silos in which we like to put them because of the way we've structured the healthcare system. They move about back and forth across the system. And so what we were particularly interested in was having information about patients' clinical outcomes be able to move with the patients as they moved from long-term care to acute care, or from acute care to home care, or acute care to primary care. How could we make this information move with the patient? So we were committed to developing and testing synoptic transition reports that could help move these, the information about these outcomes across the healthcare delivery system. And so the dimension that we created here is that the data were gathered, the data were coded in a system, and then the data were normalized so that all of them were on a 4-point scale. And how could we then present this so that it would easily move with the patient, so that we could have a synoptic report, synoptic being an adjectival form of synopsis or a summary. How do we create a single-page synoptic report? So in Ontario, in this phase, there are now 186 organizations across Ontario that are collecting the data set. And we worked very intensively with Clinical Connect in the Hamilton, Niagara, Haldeman, Brent local health integration network and the Waterloo, Wellington, LIN to try and develop a transition synoptic report, or TSR, that could move across the LIN to family health care teams, to nurse practitioner-led clinics, to community health centers, CCACs, that could move with the patients as they went. And the C-HOBIC TSR needed to provide a snapshot so that clinicians receiving it could quickly look at the report and see where there were issues related to the patient that they needed to focus on. And I'm pleased to tell you that the TSR in Ontario went live in January a year ago. So we've now got just a little over a year of experience with it. And that's what it looks like on slide 15. It's based on Nightingale's Rose diagram. The scores, as I said, were normalized so that they could be drawn on one chart, and all the concepts represent the concepts on admission and discharge. So I realize it's a little difficult for you to see, but in the top of the graphic, there's a legend that tells you which scale you're looking at, whether it's ADLs, bladder continence, pain, fatigue, dyspnea, nausea, falls, pressure ulcers, or therapeutic self-care, and tells you what the aggregated score is on a scale of 1 to 4 for each of those scales, and then it graphs them. So you can see in this case, there were some missing data, which is done intentionally so that we can show you what happens or how it looks when there's missing data. But the admission assessment is charted in red, and the discharge assessment is charted in blue. So you can see that on admission, the pain score was between 2 and 3. And on discharge, it was almost 0. Well, here in this, if you look at the legend, you look at it again, and it's invalid. The score wasn't actually described properly. So that's a point that the nurse receiving this patient, either at home care or long-term care, or the physician in her office, needs to have another look at. Similarly, the fatigue score, this one has actually decreased, and we do have measurement for it. So it's gone from being 2 down to being 1. So it's improved. Don't have to look at it too much. Same thing with dyspnea. And so this provides a snapshot, a really quick snapshot of where clinicians need to really focus. Now, there was a therapeutic self-score on discharge. therapeutic self-care score on discharge, but there was not one for admission. And the other thing that pharmacists and physicians have found is that if they look at this, then they can tell where they need to be helping their patients in terms of caring for themselves on discharge. In Manitoba, for this same phase 2, the St. Boniface Hospital included the C-HOBIC data set in its clinical documentation functionality as they implemented their all-script system at St. Boniface Hospital. And the collection of the C-HOBIC data there went live in November of 2012. So little over 2 years of experience in gathering it in the acute care setting in Manitoba. You'll recall that in the first phase, they looked at home care and long-term care. In this phase, they added acute care. And the C-HOBIC TSR in Manitoba is, because of some limitations of their system, they couldn't send it electronically as they did in Ontario across the Clinical Connect portal in Ontario. But in Manitoba, they couldn't do that. And so it's printed as part of the discharge package that goes with the patient. And their synoptic report is presented in traditional format for synoptic reports. In other words, it's textual and numerical with the scale name down the left-hand side and then the admission score with the discharge score beside it. It also was normalized to a 4-point scale. Just for ease of recognition for nurses and other readers. So, Peggy, I'm going to hand over to you for slide 18. It might be easier and save time if I just carried on changing slides for you. Hello? Is anybody there? Hello? Hello? Have I lost you? Okay. Peggy, do you want to go ahead and speak and I can change slides for you?
So I think one of the lessons learned was that leadership is key. And I think all of you know from working in projects that you need leadership at the beginning, throughout the project, and at the end. Clinician engagement and working on that, looking at the impact of any new build on the workflow from the outset is essential. Project management, and then that whole piece about change management at the beginning of the project, throughout the project, and then after the project. And consistent and continuous communication about the value. And I think while we try to do that, I think it's something that we could really learn from more about when you collect this data, how do you work with clinicians so that they see the value of this data to their practice? Next slide, Catherine.
Okay.
And determine whether there's any redundant tools already in use, or look at opportunities to eliminate redundant clinical documentation. I think one of the things we learned was a lot of sites are using the Braden scale. And so when we asked about pressure ulcers on admission, they're asking, well, why do we need to do both? The C-HOBIC measures look at the number of pressure ulcers when that patient is admitted to the hospital. And the Braden scale is more of a risk assessment. And so sometimes it's clarifying with clinicians why we're doing the assessment about the number of pressure ulcers so that we can look at the change between admission and discharge, and then how the Braden scale adds in terms of looking at risk for development of pressure ulcers. Another key lesson learned when we implemented this time at St. Boniface is we did the training on the Allscripts system with the clinicians at St. Boniface and also the education about the outcome measures. I think going forward, it's important, and maybe one of the lessons you've already learned is to separate that training on the electronic documentation out from really how clinicians use this information to add value to their practice. And identify clear and consistent processes and accountabilities for documentation and use of outcomes. So next slide, Catherine. So why are clinicians even collecting this information? And I think being very clear and consistent around that. Looking at strategies to look at the completion of the assessments, admission and discharge. I think we have better success with most sites with admission because clinicians are used to doing an admission assessment. But the discharge assessment, nurses have not always done a standardized discharge assessment. And so with C-HOBIC, we're asking the same thing on admission and discharge so we can begin to look at practice. And I think being clear with clinicians about why they're doing that. And I think the other thing is, are clinicians even doing that assessment? In Ontario, that's a minimum standard of practice that nurses complete an assessment on admission to any organization and use that to drive the plan of care. This whole thing about looking at cross-sector flow of information, and I think, you know, with the C-HOBIC TSR, there's an opportunity to share information as people move between sectors of the healthcare system to really support those transitions. Another lesson learned, look at the complexities and other priorities and politics within and between healthcare providers. And I think sometimes in healthcare we look at anything new as something different, another add-on. And I think of things like C-HOBIC, really how do we integrate this with the quality initiatives of our program and organization so that it's not an add-on, but it's an opportunity to give us information to really look at practice and quality within our unit and in our organization. Next slide, Catherine. Next slide, Catherine.
Yeah, you should have it.
So the inclusion of the C-HOBIC, we are now working, and Catherine and I are so excited about this. It's been really since we started doing this work to try and look at, we think there's value in having this C-HOBIC data set in the DAD. And the functional components are very much, as Catherine said, related to the interi, which are used in long-term care and home care in many provinces, or almost all across Canada. So there's support from interi for this work, and we think that there's value in collecting this C-HOBIC concept in the DAD and really supporting health system use. And then as well as having it at CIHI, it can be available on the portals that organizations use, but also to be able to link with other data such as the home care data and long-term care data to follow people across the continuum. So we're in discussions right now with CIHI, and we have agreement to begin collecting this in 2 pilot sites, one in Ontario and one in Manitoba, to really look at how we get that data from the clinical information system into the DAD submission. What are the resources required? And then once this work is complete, the other sites that are collecting the C-HOBIC data set will be allowed to include these in their DAD submission special project fields, and eventually it would become part of the core data set. So hopefully at the end we can have some discussion about how you think we can get other sites on board for collecting this. This is a unique opportunity. Any of you that ever worked in acute care in the DAD know that it's physician data that's entered. So the opportunity to have clinical data reflective of nursing that will add value to our practice is a huge milestone. So we're collecting this data, and it really, how does it add value? And we know in Ontario we've been collecting this since 2006. And we had Dr. Welch's do a study looking at the whole C-HOBIC data and linking it with other data sets held at ISIS. And that whole concept of therapeutic self-care showed that any improvement in that therapeutic self-care had a positive effect on readmission rates. So is your organization concerned about readmissions? How well are you preparing patients to manage their therapeutic self-care post-discharge? As well as the therapeutic self-care scores, as I said, we're a 10% reduction in likelihood of readmission for every improvement in score. And we also found, looking at the data, that nausea was strongly related to readmissions at 3, 7, and 30 days, while dyspnea was more strongly related to readmissions at 30 and 90 days. So again, taking this research back to clinicians and saying, you're discharging this patient, they have a high dyspnea score. What do we need to do so that we can prevent that patient coming back into the hospital? How do we manage across that continuum of care? Dr. Leanne Jeffs looked at the St. Michael's data and looked at the HOBIC data as predictors related to alternate level of care and length of stay, and found that higher fatigue and dyspnea scores on admission were more significantly related to longer length of stay. And so again, you assess that patient on admission, you have the dyspnea score and fatigue score that's high. What do you need to do so that you can manage that patient and prevent that longer length of stay or ALC? What other members of the team do you need to involve? What practices do you need to put in place? And as well, she found patients with higher scores for fatigue and falls and ADL composite were more likely to be discharged to complex continuing care, long-term care, or rehab. So again, we have this data. How does it add to our practice? How do we use it to really look at practice? And then Winnie Sung has recently done some work in the home care sector looking at the therapeutic scores in relationship to the use of healthcare resources such as emerge visits and unplanned readmissions and safety outcomes, and found that clients with a high TSC ability experience fewer adverse events. So it really indicates there's a need for us to focus on improving self-care for clients. I think a domain that's often overlooked. And when you introduce a standardized way of assessing that information, it really does provide clinicians with the opportunity to look at practice. So just in summary, I think you see the benefits of collecting this data set in terms of patient safety and quality of care, how we can use this data to look at quality care within our units or organizations, supporting primary health care reform, that whole across the continuum, and how we're managing people in the home care sector, accountability. I believe that clinicians need to be accountable for their practice, but what data do they have to really show that we are making a difference in the health of people we provide care for? As we showed by the C-HOBIC TSR, that whole thing of providing some continuity of information across the continuum, that focus on senior cares and transitions, and then the data aggregation allows the research such as Walter and Lan and Winnie have done. And I think the next slide doesn't show, but this is our vision, and I will send it to Cheryl. Catherine and I both tried twice to have it captured. It really just talks about that being of collect data once using many times. This data can be collected and used in your conversations with patients and their families about where they were in terms of their functional status on admission, where they are now. Clinicians can use it to look at practice when you measure continence. How are we doing in our unit in preparing our patients for discharge in terms of managing continence, in terms of improving dyspnea or managing in that post-acute care? Certainly for healthcare leaders, organizational data that they can look at in terms of the quality on their unit. And many sites in Ontario now are reporting on this data to their board, and I think that's significant. And then ultimately for benchmarking and sharing, how do we know what organizations or units are doing well in preparing patients for discharge? How can we learn from them? Are there practices that we can probably put in place in our organization or on our unit to better prepare our patients for discharge? We now have the evidence to say that if we do that, the chances, the readmission rate will be lower. And so I think across Canada, there's a real interest in reducing readmissions and managing people post-acute care. So Catherine and I, we have about 15 minutes. We're open to any questions, ideas for how we can work to get this collected beyond the sites that we've talked about. So please go ahead. And Cheryl, I'm not sure how you want to manage the questions.
Thanks, Peggy and Dr. Hanna for this presentation. I've just unmuted all the lines, so perhaps we could just have people raise their hand and indicate if they have a question, and then we'll allow them to speak and respond. I'm not going to change the hosting at this point. So does anyone have a question for Dr. Hanna or Peggy?
Or comments, we're open to anything. I guess I would say, do you see the opportunity for perhaps moving forward in your organizations with the collection of this data set? If so, why? And if not, why not? Is the timing not right? What are your thoughts around that, anyone?
Hi, this is Manal. I have a question.
Yes.
Go ahead, Manal.
Yeah, thanks. Thank you for this wonderful talk. It's really very important to learn about all of those accomplishments. I have a question like now, many nurses are being into the process of introducing minimum data sets and some type of nursing documentation to capture nurses' work. And I think most of the nurses are really challenged by how to go about this process. What would be the best approach to move forward with incorporating a comprehensive data set that really captures nurses' work? You've mentioned C-HOBIC being mapped to ICMP. What about some of the settings where some other data sets are used, like Omaha? Would C-HOBIC be mapped to Omaha? So the kind of the practical side of things, how could nurses really make use of C-HOBIC and introduce it to their policymakers and make the change in their clinical settings? Thank you.
Karen, I'll address your question about Omaha first, and then come back to your earlier question. As you are probably aware, in the development of ICNP, what the developers did was take every known nursing terminology and collect it together and develop one common set of terminologies. So Omaha is already embedded in ICNP. So if you map C-HOBIC to ICNP and you have Omaha and you map to ICNP, you'll get it. The ICNP is what's known among terminologists as a reference terminology language, which means it allows communication between and among all of the disparate nursing terminologies. Regrettably, nursing terminology developers, principally in the United States, have really worked to make their terminologies appear different. What ICNP does is provide a point of reference so that we can link across those. So anybody who's using Omaha in there as their frontline terminology, their computer vendor can map to ICNP in the background so that you can, in fact, get these same C-HOBIC concepts and extract them and provide them back to your front line. You can actually provide them back, in theory, in Omaha terminology, if you like. But because it's mapped to ICNP, that gives us the reference terminology for nursing. Does that make sense to you?
It does, it does. And,
okay.
And then my next question is that if nurses were to be asked about what would be the best system to adopt to really capture nurses' work, and I understand now ICMP could be the one that would house all of the different nursing terminologies, including C-HOBIC. So how to go about this process, and how could really they advocate for using C-HOBIC within their facilities?
Well, C-HOBIC is not just the terminology, it's the whole process. It's about the assessment instrument, which you embed in your assessment tools. It's about the documentation, which you embed in your computer system, and in the background you link it to the standardized clinical terminology that is common, either ICNP or SNOMED CT preferably, and then it's about taking those same 24 concepts, providing a picture or a graph or a representation that can go back to the nurse so they can see where their patient's strengths and weaknesses are, and then helping them to take those data and focus on the weaknesses in the care by developing a care plan that targets those, and reinforces the strengths. So C-HOBIC is about that whole process of assessment, planning, implementation, and evaluation of nursing care. And to us, that's the core and heart of nursing. The data set is merely the way that we store it in a computer. So don't think of it as just being the data set. C-HOBIC is the whole process. So the emphasis needs to be on nursing process and on building the expertise of nurses so that they use clinical evidence as well as empirical scientific evidence as the basis for their care plan and their practice.
And it's Peggy here. I just would add, Manal, that, well, if you think of the concepts we're collecting, functions, symptoms, falls, pressure ulcers, they're really patient outcomes. They're important to patients within the healthcare system if you look at some of the IOM reports. But by collecting this information, we can begin to go back and tease out what nursing's role is, looking at numbers of nursing staff and how that's impacting the outcomes. But they also recognize that within an interdisciplinary model that physio will play a role in the function, nursing may play a role, nursing in pain management, pharmacy a role. So I think by collecting these, we can really focus on interdisciplinary practice, but also be able to tease out what nursing interventions are producing better outcomes.
Certainly, and that would add to actually those nursing sensitive outcomes showing the visibility of nurses' work, and I'm really understand that concept, but I think I'm always being asked, okay, if I'm a nurse and IT people come and talk to me about what systems would work for you and would capture your work. Process-wise, I think many nurses are not clear how could they advocate for those data sets. And even the process, like they may be aware of the process, the importance of collecting assessment data to inform practice and also to inform outcomes of patient care, but they don't know how to go about it. I hoped that you would be able to give some insight on how nurses could really talk well about those questions. How do I advocate for a good system that captures nurses' work?
Well, I think that I would start by saying we have evidence that nurses make a difference in these outcomes. So there's strong evidence, and there's Diane Dorn did all the background work, and that's published in a book. So you've got the evidence. And then we're building a clinical information system, and we're starting to look at our assessment information. We'll even start by adding these questions into that assessment, and then again, into that discharge assessment. I think as we're building systems, one of the things certainly in assessments we need to focus on is getting clinicians, nurses, to add information that adds value to their practice, and maybe look at getting rid of or collecting on when you need to know it rather than if you need to know it, information that's not adding value to practice. And I think that will really help in shifting nurses from task-focused care to really outcomes-focused care. So if I was stepping into this, and this is what we did with the sites in Ontario, we've worked with many different vendors across Canada, is looking to build these, and I mean, you think of those concepts, they're asked in every sector of the healthcare system. Whenever you go in even to a patient's room, you're looking at how they're functioning, support of breath. Introducing a standardized way of assessing that information, and nurses thinking that we have evidence that we make a difference in these outcomes. So by collecting it, it will allow us to look at practice.
Thank you. Thanks, Vicki.
Any other questions or comments?
Peggy and Catherine, it's Cheryl. I have a question about the transition synoptic report. I'm really excited about that report, and I've heard about it before, but today different things were, going off in my head. Do you see a report like that being able to be used for a large aggregate group of clients as opposed to an individual client?
Oh, that's an interesting question. I don't know, Cheryl. We haven't tried it with that. Mind you, Nightingale did certainly in the Crimea. When you go back to her original work that this is based on. I'd have to spend some time thinking about it and go back to her original work, but she actually did use it on aggregate groups of soldiers in the Crimea War who were dying of dysentery as opposed to dying of wounds incurred in the fray. And so it is probably possible. I just would have to think about it for a little while. It's a good idea, though.
Yeah, I don't know whether you're aware, but we've been using HOBIC for a number of years now, and so we're just in the last phases of our research project and trying to put together that visual representation of what difference nurses are making at overall. We certainly have tools that they use the data at the front line at the point of care with their clients, but they're rudimentary, really graphs. But this would be a much more powerful way to represent aggregate populations and then to be able to pull those measures that are most meaningful for a population together. So maybe we could talk about that.
If you drop me a note, I'll send you the reference to a BBC production and the reference for Nightingale's Rose diagram, and you can maybe give it some thought.
Okay, thank you. Anyone else have any questions or comments?
Hi, it's Tracy.
Yes, hi. I think Lucia from Montreal. Are you hoping this is going to be something available coast to coast, or is it something more internal of each province?
Actually, we're hoping that eventually, when it's introduced to the hospital discharge abstract database at CIHI, then it becomes a national standard. And then there would be real motivation coast to coast to have this implemented. It is available in French, and Sylvie Jette at University of Sherbrooke has done the translation, so you might want to reach out to Sylvie and ask her for a copy of her translation.
This is my second question, yes, and I know about Sylvie, she's working on it. Thank you.
And in June, Catherine and I are now working with the Canadian Nurse Association and CIHI to have some communication strategy and some communication about this and the real value. As you know, the federal government's very interested in senior care and the value of collecting this data and how it can look at senior care across the continuum. So watch for that announcement, and all of you can take a role as nurse clinicians to advocate for the collection of this data at your site, especially acute care. I think the more sites we have ready to go on board with the collection of this data in the DAD, it will benefit us all.
I see that we have a hand up. Tracy Shaban, did you have a question?
I do. Can you hear me?
Yes,
yep.
We can.
Oh, hi. Peggy and Catherine, thank you again for, again, another very complete summary. You originally mentioned, Catherine, that the work was looked at, in order to create that original data set, that you used evidence. Would you go back and redo that work to actually increase the number of data elements? I know this was a subset of work. Is there any intention of going back and seeing if there's any other evidence that's available today? Good point.
Yeah, this is a starter set, and clearly as we do more research in nursing and in patient outcomes, there will become more evidence available that may provide us with other concepts that can be used as patient outcomes indicators. At this point, we've got our hands full just trying to get the first 24 implemented. I'm quite prepared to leave it to others to do the research to add to it. I'm not opposed to adding to it in any way. I just need to get the first 24 implemented across the country. And I should live so long. I think your point's really well taken, though. There are probably other nursing outcome indicators or patient outcome indicators for which there is new data. We have not gone back to do that, and I don't know of anybody that is at this point. That's not to suggest that it couldn't or shouldn't happen.
It's Peggy here.
Okay,
I mean, so this original work was done in 1999, 2000, and I know Diane Doran did do an update at 2005. So another review, and really did not find anything more stronger if you're working from an evidence-based approach, where you have a measure as well, and where you have a measure that's sensitive to change. There's no point collecting information for practice if it's not sensitive to change. So that review was done in 2004, 2005, and I agree with Catherine. If anyone wants to take that on, it would be a great research project now that we're down the road. I think, like Catherine said, if we lay the foundation for collecting this information, to add another concept, not as big a thing. It's really laying the foundation for collecting evidence-based information and including that in your mission and working on the value of practice. So, you know, it's worth anyone that's doing their PhD and wants to do research in that area, it'd be great to have an updated review.
The other thing I would add to what Peggy's just said, Tracy, as you know, and others on the call likely know, but just to make it explicit, this data set, the C-HOBIC data set, targets medical, surgical, chronic care type patients, adult patients. It really does not deal with pediatrics, and it, at this point, does not deal with mental health.
Right. So thank you, Catherine and Peggy, for this wonderful presentation and for your ever-present work at advancing nursing practice through C-HOBIC and informatics as well. I would like to just remind everyone that please complete the survey of this session when you receive it. And I would also like to just acknowledge InspireNet for their support in facilitating this webinar. We really appreciate their support to let us do this work together. So I'll close the call.
And Catherine, I just want to say thank you to you and thank you to CNIA and to InspireNet for providing Peggy and I with the opportunity.
Thank you, and have a good afternoon, everyone.
Bye-bye.
Thank you.
Bye.
Bye. Thanks.